Welcome back. This is part two of the intro lecture series, and we had just finished talking about leading causes of death for young adults. I do want us to talk a little bit about U.S. life expectancy right now. For both men and women, we're thinking mid-70s for individuals, but I do want to talk a little bit about the blue zones and some of the research on the blue zones. The only place in the United States is Loma Linda, California, that's been designated a blue zone. There are a lot of certain religious sects of healthy individuals there. These are places in the world where a disproportionate number of people make it past 100 years, so centenarians. And some of the research on what goes on in individuals and their lifestyle in those blue zones is all the stuff we're going to be talking about this semester. You've got people who eat really healthy foods, people who have really close social connections, people who exercise on a regular basis, people who manage their stress. So all the good stuff is clustered in these areas across the world that have been designated as blue zones. And it got the term blue zones because the first individual who was studying this would do a little blue magic marker on a map as they were studying centenarians and areas. And if you got enough of the blue markers, it actually became a zone. And so that's where the name comes from. Okay. So we've seen some changing pattern, at least in my lifetime, that what has occurred in the leading causes of death for people in the United States. Pre-COVID, it was definitely chronic disease that was strongly influenced by lifestyle. During COVID, it became number one cause of death for people in the United States. But again, a lot of that was pre-vaccinations, particularly the herd immunity that came from enough individuals getting vaccinated. Now we're at an interesting kind of place where we're seeing chronic disease from lifestyle, but then we're also seeing some brand new kinds of diseases that are a result of long COVID. And I know all of you all know somebody who had COVID, young, old, and lived with it, but has these lingering kinds of health issues. I know some people in my life having some really severe types of problems that the scientists and the healthcare providers are really trying to understand how best to treat. This is just an example of daily deaths from COVID. We saw a huge spike in 21. That was mainly Omicron. Then we had another spike mainly in January. Things have gone down since then. And the best predictor of death from COVID was being unvaccinated. We see big benefits down here for people who obtain COVID, get infected with COVID when they're vaccinated, are a lot less likely to die. We were one of the countries, industrialized countries, when we start comparing ourselves to our sister countries, where a lot of individuals in our country are anti-vaccine. A lot of that had to do with presidential influence in our culture. And we did not tend to see the same kinds of divide in people who wanted to be vaccinated and people who absolutely wouldn't take the jab, didn't want to be vaccinated in our sister industrialized countries like England, Germany, Australia, but really very different effects for what happened here in the United States. So when we look at the different factors and say this is 100% of our health, what we find is that 10% of our health is attributable to medical care, access to medical care. And that's really important because I've got another slide here in a bit talking about the haves and the have-nots. There are those like me, my family, my sons, when they were growing up as a state employee, I had wonderful health insurance through the university. And if they got really sick or if they rolled an ankle on the soccer field, I had no problem getting them an orthopedist appointment and having their ankle x-rayed and not having to worry about putting food on the table because of that expense. But there are a lot of individuals that are poorly insured, they have really crappy health insurance. And then there are a lot of individuals still that are uninsured. And those uninsured fall along certain demographic lines. Women are more likely to be uninsured than men, children more likely, individuals of color in our culture are more likely to be uninsured also. So we've got some pretty serious disparities in access to healthcare there. 40% of our health status, or you could look at the flip side of our illness status, is determined by our behavior. So that is huge. And that is why we've got a health psychology class. And we will focus on that all throughout the semester. Genetics, we're in the beginning of a genetic revolution, but most of us can't pick our parents and can't do a whole lot about our genes in this day and time right now. The other factors would be things like geographical region that you live in. It might be things like the type of work that you engage in. My work, as an example, is very safe. My grandfather was a coal miner and got black lung from working in the mines in West Virginia, and then eventually died of complications from that. That would be an example of a very unsafe job. And so the other factors would be things like that. We know that behavior accounts for 43% of all deaths, and it plays a role in 86% of all deaths. So the behavior dance that I do all semester long in health psychology is behavior is important. We need to pay more attention to it. Okay, so when we start talking about what particular types of behaviors are the most important, we've got a list here. And when I think about this, if I had a magic wand, this I had a genie or whatever, and I had a magic wand, and I could go through and change one behavior at a time for all Americans that would have the biggest impact on the health of our nation, the number one thing that I would wave that wand at would be to eliminate tobacco use. Healthcare costs are 40% higher in smokers or people who are vaping tobacco or dipping or whatnot than non-tobacco users. And if we could change this, we would prevent 400,000 deaths a year resulting from cancer, stroke, heart disease, all the complications that you get from cigarette smoking. So number one would be tobacco use. Number two would be getting people eating more healthfully and getting people exercising on a regular basis. That would wipe out another 300,000 deaths from complications, heart disease, diabetes, cancer, stroke, that kind of thing. So that would be number two. It's actually two behaviors, but it would be the most important number two. Number three would be removing underage alcohol use and excessive abusive alcohol use in those who are of legal age. Because that's attributed to a large quantity of deaths. And that could knock out another 100,000 deaths preventable from motor vehicle accidents and alcohol-related injuries. Number four on the list that could knock out another 100,000 deaths from infectious diseases would be full access to immunizations. Now, post-pandemic, we have really easy access. But there's still pockets, and particularly pockets in rural areas, pockets of poverty in the US and throughout the world where individuals do not have access. And then keep in mind, again, back to that cultural component of what happened for us in the US and what happened with the Trump administration. We've got a lot of individuals that have access to vaccines that are scared of them and adamant in their cultural and political views that they're not going to get vaccinated. And then number five in our magic wand list, if we could, would be removing unsafe possession of firearms. And I say unsafe possession because there are a lot of firearm owners out there that are incredibly safe with the way that they handle their firearms, but there are a lot of individuals aren't. This could prevent 35,000 deaths. So you're seeing here, if we change these behaviors, how many deaths we could prevent in a year by doing so. So again, another angle of looking at it on how incredibly important behavior is in our health and preventable death. Okay. So this particular study, it's a longitudinal study called the Nurses Health Exam Study. And in this study, I know that men can be nurses and non-binary people could be nurses, but in this particular study, they started with a group of female nurses, and they've been tracking these nurses across time and measuring all kinds of different things and looking at their medical health. And what they have found that of these nurses who did not use tobacco products, who exercised at least a half an hour a day, avoided a body mass index that the Center for Disease Control considers to be overweight and then beyond that obese, who ate in a healthful way, and if they drank alcohol at all, drank in moderation, they found that these healthy women had a decreased risk of coronary heart disease. Remember, that's the number one cause of death. Decreased risk of coronary heart disease by 82% compared to unhealthy nurses. That is huge effect size, you all. We don't get that kind of powerful data very often in the healthcare field. This is very powerful. And what that means is that prevention works. If you follow a healthy lifestyle, you are a lot less likely to get sick and a lot less likely to die from coronary heart disease. And we know that this healthy lifestyle prevents not only CHD, but prevents cancer. It's likely to prevent stroke. It's likely to prevent diabetes. It's likely to prevent Alzheimer's disease, all that stuff that we've talked about in those previous slides. But the punchline here, it's not a funny punchline, it's a scary punchline, was in this study, only 1% of these nurses followed all of those healthy lifestyle behaviors. And they're nurses, they're in the healthcare system. So I want us to kind of wrap our head around this. I knew, just as an example, an anecdote, I knew a nurse who smoked during her pregnancy and thought, well, my baby's going to be fine, kind of thing. But what this creates is this domino effect. If you are a healthcare provider and you yourself follow a healthy lifestyle, you are a lot more likely in your practice, whether you are a nurse, you are a cardiologist, you are a psychologist, you are a dietitian, whatever you are a lot more likely to counsel your clients or patients on lifestyle change if you follow the healthy lifestyle. If, on the other hand, you don't follow the healthy lifestyle, you're a lot less likely to counsel your patients, because then you would feel like a hypocrite. You sneak off and have your cigarettes. You've got a patient in your office with bronchitis and emphysema from smoking. You're a lot less likely to encourage that patient to quit smoking if you yourself engage in that vice. Okay, so it's quite the domino effect. So there are interventions out there and programs out there. And this is why I'm so glad to get you all in my health psychology class, because I know we've got pre-music therapy, pre-physician's assistant, pre-med, pre-psychologist, all of that in our classroom right now. And if we can impress upon you how important healthy lifestyle is, then you are a lot more likely in the future to go out and practice this kind of behavioral medicine and make more of a difference with your clients and your patients than if you have not done that. So if we can make healthcare providers, we get this domino effect with that. If we don't intervene and try to help healthcare providers be healthy, we're going to be missing out on what can be very powerful influence of the healthcare providers to the customers in our healthcare system. Okay. So some U.S. healthcare issues that we face, and we've mentioned this to some extent, the number one reason why people file for personal bankruptcy, which kills your credit, like you can't have credit cards, you can't get a mortgage, you can't get a car loan, kills your credit, is personal bankruptcy. But people file for personal bankruptcy when they've got all these medical bills that there's no way that they can pay them. So imagine somebody who's uninsured, gets in a car accident, has to be hospitalized for a while, and then they get, hundreds of thousands of dollars of bills from the hospital system that there's no way they'll ever be able to pay. So they file for bankruptcy, which is a legal move, and it erases their the necessity that they pay back those bills, but then it wipes out all of your credit. So again, you can't get loans and all that kind of stuff. We have very large disparities in the US healthcare system. People of color are a lot more likely to be the have-nots. People in rural areas are more likely to be the have-nots. Women compared to men, children, people of low socioeconomic status are more likely to be the have-nots. You all lived through history when Barack Obama was in office and he passed the Patient Protection Affordable Care Act. First of all, our federal government, the legislature, passed this. Our Senate approved it, and then Obama signed it into law. And it was the Patient Protection and Affordable Care Act. It ended up getting nicknamed Obamacare, which is easier to say than all these words. But part of the problem in getting nicknamed Obamacare is there were a lot of people, particularly individuals that are more likely to align with the Republican Party, who didn't want Obamacare. This law was meant to, when we say narrow the disparity gap, it was meant to get more people insured. So there be more of the haves and a lot less of the have-nots in our healthcare system. And just to give you an idea of how powerful that law was in getting people insured, we saw this rapid, so this is the percent of people covered by public and private health insurance in the United States. And we saw this very rapid increase because a lot of individuals bought into the exchange program, or their government offered more of public access to healthcare, or private employers offering more. But by offering more of these options, we have a lot more individuals insured now than we did previous to Obamacare. That has actually been quite helpful in our healthcare system. So instead of, like, say, an emergency department seeing somebody who's uninsured and then having to figure out how to pay for their care, which is really, I don't know what's going on there. all the other people who had insurance who paid for their health care, that ends up paying for the people that couldn't pay. Somebody has to pay for it. So a lot of doctors and emergency departments, as an example, are able to collect for the people that they treat because of their healthcare coverage. So there's been some nice side effects of that, as well as more people, when they are sick and need healthcare, able to go get it because they now have insurance when they did not have it prior to that. Okay, so let's take a look at what's going on in the healthcare industry in the United States. This is some really interesting data, I feel like, when we compare ourselves to our sister countries. So our sister countries would be other industrialized nations: Germany, Canada, France, Australia, United Kingdom, Great Britain, England, whatever, and Scotland. They've all seen inflation in their healthcare costs over time. And keep in mind, this truncated back in 2004. But I just want us to really see how more quickly the United States spending escalated exponentially relative to our sister countries over time. In the United States right now, 2022, our gross domestic product, which is the stuff that we spend our money on, 20% of our spending is on healthcare. So for every, $5 that we as Americans spend, $1 of that is in our healthcare system. And it's been rising. Everything is more expensive. Like, food's more expensive now than it was, say, 3 years ago, as an example. It's hard to get a lunch for, under $10, as an example. So there's inflation. There's always inflation. Things keep getting more expensive. But healthcare has risen 3 times the rate of inflation since the 1960s. So much more acceleration than the inflation rate. And just to give you, you don't need to memorize this stuff, but I just want to give you like a sense of it. Back in the 80s, we were paying $1,000 per person per year on healthcare. By 2008, $7,000, 2015, $8,000. By 2023, we're spending $12,000, almost $12,500 on people per year in the United States. And just to ground that, the world average is at about 5,000. So we're at more than double the average in the world in what we spend in healthcare. And I just want to let that sink in. We've got really expensive costs in the United States on our healthcare. And you would hope, kind of like a bottle of fine wine, you spend more money than less money on a bottle of wine, you expect it to be better. We are not fine wine, unfortunately. The United States spends the most. And interestingly, there, South Africa is the only other developed country in the world that does not have universal health care like us in the United States. So all of our sister countries that I just spoke about have universal health care, which means it's socialized medicine, which means they're taxed at a higher rate than we are taxed, but there's a big pot of money that is their health care. And whenever they need health care, they go to the dentist for free, go to primary care for free, and in some cases even go to specialized healthcare for free. I mean, again, they paid for it in their taxes, but they're not paying for it through an insurance company, and they're not paying for it out of pocket. Now, one of the downsides of universal healthcare and socialized medicine is they ration their healthcare, and they're less likely to offer very specialized, high expense healthcare to try to save one life. And we do a little bit more of that here in the United States with that. But we do not have universal healthcare. If we did, everybody 100%, versus the slide that I showed you a minute ago, 100% of people would have access to healthcare. We would not have haves and have-nots. Now, I could own the fine wine analogy if we were healthier, but we're not. Okay. We have a shorter lifespan, higher infant mortality versus our sister developed nations. And the World Health Organization, they rank the nations on all kinds of different health care metrics. They have ranked us 37th in healthcare performance, and they've ranked us 72nd in overall health compared to all of the other nations. So it doesn't fit the fine wine analogy. It is that we are spending excessive amounts of healthcare, but it's not making us the healthiest nation in the world. Okay. So that begs the question, why the expense? Why are we so dang expensive? What's going on there? And there are reasons for that. Just another graph here to kind of show you, this is the national per capita, means per person or percentage of people, that kind of thing, per capita expenditure in the United States. And this goes from 1960 up to 2021. And you see, we just keep going up and up and up. And that's the number we saw on the last slide, that 12,500 per person. So just a visual to kind of hit it home. We are spending a lot. Okay, so let's do this slide and then I will end this portion of the lecture. So why the expense? Technology and diagnostic imaging. And this is a little bit of a graph just to show you over time how much more we are using for the fancy technology diagnostic imaging. When, as an example, back when I had my sons, I got a 2-dimension ultrasound. It was black and white. I remember the first one I saw was like, I got a little bean in there. And then you saw one a little bit later, got a little alien in there. And then by the end, oh, there's a whole baby in there, kind of thing. But it was black and white, pretty cheap ultrasound. Nowadays, we've got these ultrasounds that we routinely use on babies that are in color. You can get them in 3D. You can watch your baby dance in utero. I mean, it's just like really fancy stuff. I have found it fascinating that you will even see billboards advertising what hospitals have what kind of imaging equipment, because there's all this competition. Come to my clinic, come to my office, come to my hospital, because we've got the functional MRI, or we've got the the imaging of your baby that shows your baby dancing in 3D color and all that kind of stuff. Yeah, we're spending a lot of money on this really fancy diagnostic imaging equipment. We recommend and we use a lot of costly treatments, but we're ignoring cost effectiveness. So as an example, there was a wonderful study a couple of years ago that took the newer blood pressure medications, hypertension medications, the newer ones that were more expensive, and they randomly assigned all these people that had hypertension, randomly assigned, they either got the newer drugs or they got the older drugs that have generics that are cheaper. And what a brilliant study. We need more of this kind of stuff. And it basically found that there was no difference in the new expensive drugs versus the old generic, less expensive drugs. And there was a big push to get healthcare providers to, if they had their patients on the newer stuff, have them switch up and prescribe to them, because usually once you go on hypertension meds, you're on them for the rest of your life, unless you're doing really dramatic lifestyle change to bring your hypertension down to normal blood pressure. So, you think about it like putting a 40-year-old on it who's going to live to 80. That's 40 years of their life that are going to be on that medication. So you can see how being on a cheaper medication that's equally effective compounds the savings over time. Being on the newer stuff compounds the expense over time. I was sitting one day and I go and get allergy shots because I'm allergic to the world we live in. And I was sitting, after you get an allergy shot, you have to sit there for 20 minutes because they want to make sure you don't have a bad reaction and die, which is, kind of courteous. And I was sitting there in the waiting area after I got my allergy shots. And this woman goes back and she's talking to the nurse at the nurse's desk. And she said, I was in here last week. Dr. So-and-so prescribed such and such medication for me. And I want to talk to you about it. And I want you to report this to him. That medication would have cost me $4,000 a month. And I'm sitting there going, whoo, this is a little anecdote for my health psych class. And she asked the nurse, did you know how expensive this medication is? And the nurse is like, no, I don't. Well, does the doctor know how expensive this medication is? And she's like, I don't know. And I'm waiting for her to go, oh, this is really important information. Let me make sure I let your doctor know this right away, and I will have him be in touch with you. There was none of that going down, unfortunately. But I was sitting there thinking, I made good money as a professor. There's no way I could afford that. Nobody, you'd have to be a billionaire to be able to afford that. Uh-oh, we got a dog on the run. Anyways, we need to be paying more attention to this. And I don't know if you all know, but in a lot of doctors' offices, the pharmaceutical reps, they come in with their samples and they present little presentations on how great their medications are, but rarely is it hit home. Do the doctors necessarily know what are the ones that are the best to prescribe that also have cost effectiveness to them? Other issues, we've got the aging population. We've got the baby boomers were post World War I and World War II, where a lot of people, we went way back to a traditional family lifestyle, a lot more likely moms, women married men, women didn't have careers, they were homemakers, that type of thing. And there were lots of babies made, baby boom. Apparently they came back from the war kind of horny. Big baby boom. That is my parents' generation. It's probably your great grandparents, maybe beyond generation. But there's this big proportion of the baby boomers who are in the twilight years. They are very politically active. They usually get what they want in terms of politics. They lobbied and, for example, got the Medicare which is 65 and older, that federal money. They got their medications covered, as an example. That was something that the baby boomers did. They're aging. And remember, we said age is a predictor of illness and age is a predictor of death. Well, they're very politically active. And they are using, there are a lot of them, and they're using a huge proportion of our healthcare system. We younger people in our tax base are supporting their Social Security, and we're supporting their Medicare. And there's less of us. Okay, so there's more of them, there are less of us younger people. So we got issues going on there. Another reason why it is so expensive is the specialty training of medical doctors. And that makes sense. The more specialty we used to have, like all doctors were primary care, local town doctor, delivered babies, took care of the elderly, pulled your teeth when they were rotten. They did everything. But now we've become so specialized, where a lot of different trainings, not only do you go to med school, good 5 years there, but then residencies have gotten longer. And then if you really want to specialize, you go into fellowships beyond the residency years. And so you're talking, for a lot of physicians, they've had beyond their bachelor's degree, beyond 7 years of med school residency training, some of them up to 10 plus years of specialty training. Yeah, you want to make good money, and they deserve to make good money for that level of investment in their own education and their specialty practice. What has been a side effect of that is expense. A surgeon's hourly rate is going to be much higher in payment than, say, a primary care physician's hourly payment. And that's fair, right? When you start thinking about that. But another issue that has happened here is we've broken up our healthcare system into body parts. In order to be so specialized, say for oral surgery, in order to be so specialized in podiatry, taking care of feet, gynecology and obstetrics, you got to be specialized in the lady parts, that kind of stuff. We've become so specialized in the body parts that one of the places where this is good is that you go to see a podiatrist, he's going to know how to deal with feet problems. You're good there. But where it's become a problem is where we get fragmented care. And I even had an experience with this recently where I was in a doctor's office and I had this new symptom that was occurring post-vaccine. And I wanted this particular practitioner to take a look at this new symptom. And it didn't involve clothes off and weird stuff, anything like that. And the practitioner even told me, pointed to a place in the body and said, "We do this area." Meaning, look, lady, you're complaining about a symptom in an area, and that's not us, right? And I was like, okay, I guess, okay, yeah. Body parts, yeah, that's been problematic. It's really problematic for individuals who have systemic disease that's affecting multiple body parts, and you don't have that coordination of care. So there's ups and downs of that. We really focus on intervention care as opposed to preventative care. So, as an example, if you're a walking, talking time bomb about to have a stroke or a heart attack, we probably can't get you into a cardiac rehab program for prevention of the stroke or the heart attack. But boy, you have that heart attack or you have that stroke, now insurance will pay for you to go to a cardiac rehab program or a stroke rehab program. So we're practicing a lot more of the intervention care than preventative care. One of the really nice things, though, that the Obamacare Patient Protection Affordable Care Act did was require every single insurance company has to cover prevention. They cannot just cover only if you have a medical diagnosis and you're getting treatment. They have to cover prevention. That was really nice on my healthcare plan for all the state employees like us professors. I used to have my annual checkup and I had a copay for it. They even got rid of our copay. So we can go for our annual checkup and it covers 100% of it. We don't even have a copay out of our pocket. So requiring that has been very important, particularly important for integrative medicine. We've got the support for the types of practitioners that practice integrative medicine and preventative medicine is now covered, has to be legally covered by all insurance companies that have coverage. Pharmaceutical companies is a absolutely huge market, and so much of the way our healthcare system works is driven by big pharma. And in this particular graph, you can get a little bit of a sense of how much more we're spending per capita per person with our pharmaceutical expenses. So very heavily biomedical medicine, very heavily, very, very powerful political lobby, big pharma. Okay. Another reason why it's been so expensive, and you're going to be hearing, you've heard a lot of it already, you're going to be hearing more of it. We are ignoring behavioral, psychological influences. We've been ignoring the lifestyle stuff in our healthcare system for a long period of time. We've been ignoring all these behaviors that make people sick. We've been ignoring the power of psychological disorders or mental illness. People with psychological disorders, or even just simply people who are just really stressed, go to the medical healthcare system for their physical symptoms a lot more frequently. So they're more likely to be frequent flyers. People with this MDE, this would be depressed people. So major depressive episodes have twice the medical costs as people who are non-depressed, as an example. So by ignoring this, particularly ignoring this Patient Protection Affordable Care Act, is huge and is part of why things are so expensive. Okay, I'm going to stop part 2 of the intro lecture, and we will pick back up on this with part 3.